Bismillah ar-Rahman ar-Rahim. I am Dr. Noha Muhammad Ibrahim. I am a consultant of anesthesia and intensive care. I'm working in King Fahd Teaching Hospital in Al-Khobar. We will discuss the acid-base disturbances and the EBG interpretation, and I will divide this topic on 3 lectures. And actually, in the presentation, I'm mixing the physiology, pathophysiology, and the practice in the same time, so it make it easy for you and keep you concentrating with me. First of all, do we need to know about EBG interpretation? I think anyone of us, anyone having even 1 week of experience working with patient will know how much it's very important to interpret the EBG. You are facing the EBG paper, I think, with most of the patient in ER, in ICU, or in the ward if they are deteriorating. You need to know the EBG and get the information from it. This will help you to take decision in the management and to guide you during the management, and also for medico-legal. When you are taking decision regarding intubation or ventilation, you need to do EBG before you take this decision. So, and EBG interpretation is very important to all the physicians, okay? And we need to have good background on the physiology and pathophysiology to make the important and facts we get from the EBG easy for us and easy to remember, okay? The content of this lecture, which you will know after we finish, but they are not told in sequence, we will talk about what is the pH, the source of hydrogen ions and the hydrogen ion homeostasis, the EBG normal limits and cutoff values. We will speak about the effects of acidosis, effects of alkalosis, the metabolic disorder alkalosis or metabolic acidosis, and we will discuss the respiratory disorders also, either alkalosis or acidosis, concepts which may be disturbing some of us. The anion gap, osmolar gap, and urine anion gap, and delta gap will be discussed also. Then we will discuss in details the traditional way of assessment of acid-base disorders, and I will tell you about the algorithm for interpretation, which will make interpretation of EBG for you super easy, and then there will be many cases. First of all, let's start the lecture by what is the pH. First of all, you will see the pH in the EBG. What is the pH? pH is the measure of the amount of free hydrogen ion in the plasma or in the solution. So it is measured by a scale. Why we are not measuring the hydrogen ion, which we want directly? Because it is very minimal and very tiny amount. It's very hard to get it. Another reason, it's highly reactive and it has a very big effect in short or in small range. So they are measured on a scale, okay, logarithm scale, because they are very tiny, present in very tiny amount, measured by nanomole, and the nanomole is 1 millimole equal to million of nanomole. So imagine how much it is very small. And the pH is the negative logarithm of the hydrogen for the base 10 of hydrogen ion concentration. This amount of hydrogen ion concentration at the pH of 7.4 is about 40 nanomole. Okay? And I want you to imagine that the compare between the potassium and sodium are measured by milli equivalent, but here it is measured by the nano millimole. The amount of potassium actually in the blood is more than the hydrogen ion by 100,000 times. Okay? So the pH is a log scale. It is the negative logarithm of base 10 of hydrogen ion concentration. From where these hydrogen ions are produced? from food, from the metabolism, any activity in the body, any metabolism, any activity in the body will get release of acids, and these acids will get the hydrogen ions. About daily we have maybe a load of 100 millimole. Imagine, each millimole is 1 million of nanomole. So, and we need for the proper enzymatic function to 40 nanomole of free hydrogen ion to keep the enzymatic function optimum. So the body is striving all the time to keep the hydrogen ion concentration in very narrow range, and this can be done or reached by three mechanisms. First of them is the buffer, and these buffers are present everywhere, extracellular and intracellular. Once they find the hydrogen ion, they catch it like a sponge. Okay, they're working within second, immediate effect. The most important of these buffer is the bicarbonate, also the protein and phosphate and hemoglobin itself. Buffers are like sponges. When the hydrogen ion amount increase, they will absorb it. When it decrease, they will release it. Simply. And what is the enzyme which catalyze this is the carbon anhydrase. All the time carbon anhydrase is working. Hydrogen ion amount increase, take it and make it with the HCO3 through the carbon anhydrase. It will be converted to water and carbon dioxide. Carbon dioxide will be released by the lung, and HC and the H2O will be released by the kidney. And vice versa, if the hydrogen ion amount decrease, carbon dioxide will increase, and also that will combine with water and form the same amount, and then will form H2CO3, and then again dissociate to HCO3 and hydrogen ion to increase the amount of hydrogen ion. The second mechanism for controlling the hydrogen amount is through the lung. And here the lung working also within minutes, immediately, working very rapidly. And of course the duration to start and to get the proper effect, which is from 50 to 70% only from the disturbance, depend also on the vitality of the lung. So the correction to the disturbance will be 50 to 70%. If there is metabolic acidosis, there will be hyperventilation and wash of carbon dioxide. But this wash of carbon dioxide will never make the pH again reach it to 7.4. If there is metabolic alkalosis, there will be respiratory depression and accumulation of carbon dioxide. But also this will never make the pH again 7.4. The compensation usually will be up to 50 or 70%. The third mechanism is the kidney, and here kidney work by correct or interfere in this hydrogen ion concentration by the maintaining the electroneutrality through secreting or absorbing sodium and chloride ions in exchange of HCO3 or hydrogen ion. The GIT and liver also has role in hydrogen ion concentration regulation. This is the Henderson-Hasselbalch equation. Most of us, I think, heard about it. Maybe it looks complicated, but it is easy if we simplify it. What we want to know from this equation is that the pH is in direct relation with the HCO3 and in inverse relation with the carbon dioxide. This means that if the bicarb increase, the pH will increase. They are going in the same direction, while they are going in the reverse direction of the carbon dioxide. If the carbon dioxide increase, the pH will decrease. Okay, and vice versa. As I told you, the pH should be kept in a very, the amount of hydrogen ion should be kept in tiny amount, in very limited value, which is range, range. It is from the hydrogen ion from 35 to 45, and this equals to the pH of 7.45 to 7.35. Okay, and outside of this range there will be abnormality, but reaching till 6.8 of acidosis will be incompatible with life. If it's the pH reduced more than 6.8, which equal at that time at this pH, the hydrogen ion concentration will be 160 nanomole per liter. This will be incompatible with life. So when the hydrogen amount concentration multiplied by 4 increased up to 4 times from the normal range. While in alkalosis, when the pH reached to 7.7, and here the hydrogen ion will be decreased to 20 nanomole, halved, as you see, will be incompatible with life. So that we can say that the human body is more tolerant to acidosis more than alkalosis. While in practice, maybe sometimes we deal with acidosis more seriously, while alkalosis is more serious. Actually, we should deal with the two, because the body will not tolerate pH more than 7.7, while the pH is up to 6.8. After this will be incompatible with life also. So the pH, as I told you, is the negative logarithm of hydrogen ion concentration. The B here, not a tension, not a pressure, not nothing. It is just the power or the strength. And this table will show you the correlation between the pH and hydrogen ion. Luckily, at 7.4, it is 40. Okay, at 7.35, it is 45. Okay, at 7.45, it is 35. Okay. Now we need to know the normal range and the cut-off number for acid-base interpretation. Okay, when you hold the EPG analysis paper in your hand, you look to the pH. The normal pH is 7.35 to 7.45, but the normal which will count on it in acid-base disturbance is 7.4. Okay, above 7.4 will be alkalosis, less than 7.4 will be acidosis. Okay, the HCO3, the normal range is 22 to 26 millimole per liter, but above this range, above the HCO3, above 26 should be alkalosis. No, in EPG interpretation we will say 24 is the cut number. Above 24 we will consider this metabolic alkalosis. Below 24 we will consider this metabolic acidosis. Then the BCO2 and the number, the range from 35 to 45, and the cut-off number is 40 millimeter mercury, and above 40 we'll say there is respiratory acidosis. Less than 40 we will say there is respiratory alkalosis. Don't also forget to comment on the oxygenation in EPG interpretation. So in EPG interpretation we are doing two things: acid-base interpretation and oxygenation evaluation. How we evaluate the oxygenation of the patient? There is actually different methods, but the simplest and what we need for our lecture will be to know the BF ratio. The amount of BaO2, I cannot tell what the normal and what is the cut number for interpretation, because it is not logic to tell this is this EPG normal oxygenation or no without knowing the FiO2. So to comment on oxygenation in EPG, you should know the FiO2. The FiO2 is the amount, the concentration of the oxygen the patient taking. We are doing this comment or this measurement by measuring the BF ratio. What is the BF ratio? Is the ratio between the BaO2 and the FiO2. Normally it is from 400 to 500. For example, if the patient taking FiO2 is 50 and the BaO2 is for him is 250, it will be 250 divided by the FiO2, which is 50, Okay, then multiplied by 100 because it is 50%. If I do is 50%, it will be 500. Okay, and we will talk about oxygenation in details later. This is comparison between the ABG taking from the artery and taking from the vein in patient on room air. This not valid. These number are not valid for any patient taking supplemental oxygenation even with nasal cannula. Okay. Now types of acid-base disturbances. Of course, it is acidosis or alkalosis or mixed disorders. Yes. What we want to know the effect of acidemia. Acidemia and alkalemia. Acidemia means that the pH less than 7.35 and for the ABG interpretation will be less than 7.4, and we need to mention that the major consequences of acidemia will occur when the pH less than 7.2. What these effects on the heart? There will be impaired contractility and reduction in the cardiac output and arrhythmias. On the vascular, there will be arteriolar vasodilatation resulting in hypotension. On the respiratory, pulmonary vasoconstriction. So in the systemic blood vessels, there will be vasodilatation. On the pulmonary blood vessels, there will be vasoconstriction, increasing the pulmonary vascular resistance, and there will be hyperventilation also. Hyperventilation, why we are doing hyperventilation? To decrease the carbon dioxide. To decrease the carbon dioxide, so decreasing the acid, reversing the acidity. Neurological effect of acidemia is confusion, obtundation, and coma. On the metabolism, there will be decreased response to catecholamines, so that when the patient on catecholamine on vasopressors because shock from any reason, and the pH less than 7.2 and HCO3 less than 12, we are giving bicarb infusion or better to be bicarb boluses to correct the response to the catecholamine. Also, acidemia will cause insulin resistance and hyperglycemia, will inhibit glycolysis and inhibit ATP synthesis and cause hyperkalemia. Why acidosis will cause hyperkalemia? What do you think? The presence of hydrogen ion outside will make it be enter to the intracellular space and then get rid of potassium outside the cell to correct for this to maintain the electron neutrality. Alkalemia, what it will cause the alkalemia? Alkalemia will be there when the pH is more than 7.45. But also again for ABG interpretation, when the pH more than 7.4, this will be alkalemia or alkalosis. Okay? The major consequences of alkalemia will occur when the pH more than 7.6, but it is incompatible. 7.7 will be very dangerous and the patient will not stay alive if we did not interfere quickly. On the cardiac effect, there will be increased contractility until the pH is 7.7. After this, coronary vasospasm will occur and decreased contractility and refractory ventricular arrhythmia will occur. On the respiratory, there will be vasodilatation of the pulmonary vasculature, the reverse of the acidosis. And there will be respiratory depression. Why respiratory depression? To increase the carbon dioxide, which is the acid, to decrease the pH again, which can frustrate respiratory depression, which occur with metabolic alkalosis or with any alkalosis, who can frustrate the efforts to wean. Neurological effects of alkalemia: vasoconstriction of the cerebral vessels, headache, delirium, tetany, and seizures. Metabolic effect: electrolyte disturbance, hypo, everything, potassium, phosphorus, calcium, magnesium. Okay, also stimulation of anaerobic glycolysis and lactate production. Types of acid-base disturbances: as you see, it is respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. I want you to notice something very important and keep it in your mind. So, in respiratory acidosis, the pH is going down, okay, the carbon dioxide is going up, and if there is compensation, it will be by increasing the HCO3. In respiratory alkalosis, the pH is going up, the carbon dioxide is going down, and the compensation through the metabolic system will be through decreasing the HCO3. In metabolic acidosis, the pH going down, the HCO3 and PCO2 are going in the same direction. The HCO3 is decreased because it is metabolic acidosis, and the carbon dioxide will compensate by going also down in the same direction. Okay, while in metabolic alkalosis, the pH is increasing, the HCO3 is increased, and the carbon dioxide will increase in trying to compensate. So in metabolic problems, usually the pH, the HCO3, the carbon dioxide are going in the same direction. Okay, in respiratory problems, they are going in reverse direction. Now let's talk about selected etiologies of respiratory acidosis and selected etiologies of respiratory alkalosis. What do you think may cause respiratory acidosis? Okay, the airway obstruction, of course, either upper or lower. COPD patient will have carbon dioxide accumulation, carbon dioxide elevation, and also HCO3 will be elevated. Also, okay, asthma and other obstructive lung disease, CNS depression, depression of the respiratory center by either trauma, tumor, cerebrovascular accident, or drugs like opioids will cause the same also. Sleep disorders, breathing, neuromuscular impairment like in Guillain-Barré syndrome or in myasthenia gravis, increased carbon dioxide production due to high carbohydrate intake, shivering, seizures, malignant hyperthermia or hypermetabolism, and of course incorrect mechanical ventilation setting. What is selected etiologies of respiratory alkalosis? CNS stimulation like in fever, pain, fear and anxiety, cerebrovascular accident, cerebral edema, brain trauma, brain tumor, and the most important is CNS infection. Hypoxemia or hypoxia also will cause respiratory alkalosis because the patient will try to compensate for this hypoxia, like in lung diseases or profound anemia or low FiO2 in high altitude. Also stimulation of chest receptor, which happen in pulmonary embolism or pulmonary edema or pleural effusion. Drugs or hormones, drugs like salicylates or catecholamines, or hormones like progesterone, medroxyprogesterone or progestins. Pregnancy, of course, also the same reason. Liver disease and sepsis, okay, and hyperthyroidism. Of course, incorrect mechanical ventilation setting. Okay, let's finish our talk now for this and take a break, and then we will go to the metabolic disorder.